Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In the previous videos, I talked about the initial assessment and management, indication for neurospecialty referral, and pathophysiology of traumatic brain injury. I'll put the links in the description below in case you're interested. This is the final part of the series about traumatic brain injury, and I would like to talk about detailed monitoring and management of patients with severe brain injury on neurointensive care unit, and also discuss late complications of traumatic brain injury briefly. On neuro ICU, we can monitor patients clinically by neuro observations such as GCS, pupillometry, motor examination, and brainstem reflexes. Intracranial pressure and cerebral perfusion pressure monitoring is a standard routine in specialist neuro centers. Sophisticated neuromonitoring techniques, for instance, pressure reactivity index, cerebral microdialysis, brain tissue oxygen monitoring, continuous surface EEG, evoked potentials, and transcranial Doppler can be used for advanced neurological monitoring in specialist centers. Intracranial volume is a constant in adults, which means that an increase in any of the intracranial components will result in a decrease in one or more of the others. Normally, it is composed of blood, CSF, and brain tissues. Any pathological lesions can put pressure on normal intracranial structures, and the degree of compression varies depending on the location of the lesions. For example, posterior fossa and infratentorial space are much more dangerous areas because they are small and limited compartments, and there is a risk of direct and life-threatening brainstem compression. Increased ICP can occur in approximately half of all patients with mass lesions and about one-third of all patients with severe diffuse brain injuries. Uncontrolled refractory raised ICP above 20 to 25 mm mercury is strongly associated with morbidity and mortality. Intracranial pressure is the cerebrospinal fluid pressure, ideally measured via a catheter in the ventricular system, with its tips at the level of the foramen of Monro without loss of fluid from the system, and it is equivalent to ventricular fluid pressure. ICP can be recorded at various sites in the cranial vault, not only in the ventricular system, also in the brain parenchyma and in the subdural, subarachnoid or epidural spaces. Please bear in mind that ICP values could be different depending on the locations of measurement. Subdural and epidural ICP recordings are not particularly reliable, hence they are not recommended for monitoring. In adults, normal ICP should not exceed 15 mm mercury, even if they are in supine position, and in newborns and children, less than 7.5 and 10 mm mercury respectively. Continuous digital ICP monitoring is found to be more accurate than hourly episodic measurement. Guidelines suggest that ICP monitoring should be considered in all patients with severe brain injury, whose GCS score is below 9 and positive findings on CT. Despite that, ICP monitoring is not useful in patients who are considered to be unsalvageable. Also, patients with less severe injuries and high GCS motor score of more than 5, who are not expected to have persistent increase in ICP, will not need to be monitored. So, before clinical decision making, whether or not ICP monitoring should be started, we should check any criteria of exclusion in patients, such as bilateral fixed pupils, loss of extracranial lesions which are difficult to manage, advanced age with background multiple comorbidities, and untreatable lesions on CT scan. ICP monitoring is an invasive procedure, thus it is contraindicated in patients with coagulopathy as well. When there is no contraindication, ICP monitoring is recommended in patients with unequal pupils, diffuse axonal injuries with risk of intracranial hypertension, ongoing primary decompression via craniotomy, and potentially evolving lesions on CT scan. Now, I would like to discuss how intracranial pressure plays an important role in affecting blood supply to the brain. Cerebral perfusion pressure is the net pressure gradient which causes cerebral blood flow and drives oxygen delivery to brain tissues. It is the difference between mean arterial pressure and intracranial pressure. Therefore, to maintain the cerebral perfusion pressure around 60 to 70 mm for optimal blood flow to the brain, in patients with traumatic brain injury and raised ICP, we need to increase MAP target and also commence measures to lower ICP when its value exceeds more than 22 mm according to the latest European guidelines. Pressure reactivity index is a moving correlation coefficient between slow waves of intracranial pressure and mean arterial blood pressure, and it could be calculated by multimodal neuromonitoring software. It is a validated dynamic marker to measure cerebral autoregulation and cerebral vascular reactivity after traumatic brain injury, and it is the most widely used index. It essentially displays whether ICP rises or falls in response to rising MAP. Here is Larson curve to illustrate the cerebral autoregulation and the relation of cerebral perfusion pressure and cerebral blood flow. Basically, to maintain cerebral blood flow within autoregulation range, afferent cerebral arteries vasodilate as arterial blood pressure decreases towards the lower limit, and vasoconstrict as arterial blood pressure increases towards the upper limit of the range. Positive pressure reactivity index is seen when a rise in MAP leads to a rise in ICP, which means cerebral autoregulation is impaired. Negative pressure reactivity index indicates a compensatory cerebral vascular response and intact cerebral autoregulation, which leads to a lower ICP in response to an increased MAP. Evidently, a single cerebral perfusion pressure target is not sufficient due to the diversity of patients. Hence, it may be of more benefit to optimize target cerebral perfusion pressure tailored for individual patients. Cerebral microdialysis can indicate cellular metabolism after brain injury by monitoring metabolic distress, which can be useful to guide management. It can estimate extracellular interstitial concentrations of small molecules like glucose, lactate, and pyruvate for calculation of lactate-pyruvate ratio, glutamate, and glycerol, as well as larger molecules in interstitial fluids such as inflammatory mediators. Elevated cerebral microdialysis values can hint the possibility of raised ICP with or without impaired cerebral perfusion pressure. High lactate pyruvate ratio is also associated with secondary ischemic injury and frontal lobe atrophy at 6 months post-traumatic brain injury. Therefore, it is related to poor clinical outcomes. Monitoring of brain oxygen levels can be done focally by using brain tissue oxygenation monitors as partial brain tissue oxygenation, PbTO2, or globally by using a jugular venous catheter as jugular venous oxygen saturation, SJVO2, to titrate oxygenation and avoid brain hypoxia and ischemia, consequently allowing the optimization of hyperventilation in the treatment of intracranial hypertension. Continuous EEG monitoring is useful for detecting non-convulsive status epilepticus. Electrocorticography is an invasive form of EEG monitoring where recording equipment are placed on the brain cortical surface intraoperatively. It can detect neural and astrocyte depolarization waves known as cortical spreading depression, which can be associated with poor prognostic factors such as cerebral vasoconstriction and ischemia with impaired autoregulation, cerebral metabolic crisis, increased ICP, expansion of intracranial lesions, all of which can give rise to secondary brain injury following traumatic brain injury. Transcranial Doppler is the non-invasive method to estimate cerebral autoregulation. The pulsatility index can be used as an indirect marker for adequacy of cerebral perfusion pressure and also intracranial compliance. However, transcranial Doppler is operator dependent and quite unreliable. Neuroimaging is getting popular for the diagnosis of specific pathophysiological conditions and their monitoring. CT and MRI perfusion scan can produce mapping of regional cerebral blood flow and volume, so it can identify the area of brain penumbra. CT and MRI diffusion scan can detect the area of cerebral edema. MRI spectrometry can suggest areas of cerebral ischemia by mapping of cerebral metabolites. Now, let's discuss intensive care management of patients with severe traumatic brain injury. The main aim of the management is to provide high-quality general intensive care and to prevent or reduce secondary brain damage while the underlying pathology is resolving. Here, in this video, I'd like to focus more on the specific treatment strategies. For the general intensive care management of neurotrauma patients, it is pretty much similar to management of post-cardiac arrest patients. I've put the link of the video about post-cardiac arrest care in the description below if you're interested. Most ICU apply multi-tiered protocols and a scale of therapeutic intervention to manage increasing levels of intracranial hypertension. The scales can vary depending on local hospital guidelines. Specific management strategies of patients with severe traumatic brain injury can be divided into surgery for hematoma, control of intracranial pressure and cerebral edema, treat intracranial infections, and seizure management. Immediate surgery is often the primary decompression and treatment for large intracranial hematomas and brain contusions, and also for depressed fractures and other penetrating injuries. Neurosurgeons will decide when and which patients are appropriate for neurosurgical interventions. As I mentioned earlier, specific interventions are required when ICP more than 22 mm mercury, and we should aim cerebral perfusion pressure of 60 to 70 mm mercury. Basically, appropriate sedation and analgesia are essential since stress, cough, and pain may cause a rise in ICP. Furthermore, adequate levels of sedation can reduce the incidence of early seizures and non-convulsive status epilepticus. Short-term sedatives and analgesics, for example, propofol and remifentanil or fentanyl, are recommended in patients who are likely to have prompt recovery. In patients with catastrophic CT findings, initial raised ICP with high risk of secondary insults, we can add benzodiazepine like midazolam and lorazepam. Once the ICP level is successfully controlled, daily sedation hold may be useful to assess neurology and to avoid oversedation, cardiovascular depression, and longer duration of mechanical ventilation. Mechanical ventilation is mandatory initially to facilitate proper ventilation and gas exchange during deep sedation. Hyperventilation can efficiently lower intracranial hypertension, and it should be one of the first maneuvers in acutely reversing transtentorial herniation while preparing for surgical evacuation of a mass lesion or for decompressive craniectomy. Hyperventilation can result in CO2 washout, therefore causing cerebral vasoconstriction and decreasing cerebral blood flow and volume, and consequently intracranial pressure. As I mentioned in my previous video, we need to be very careful to avoid ischemic cerebral hypoxia as its side effect, so we should carry out hyperventilation no more than half an hour, aiming PaCO2 around 4 kPa and also together with 100% oxygen while monitoring jugular bulb oximetry or brain tissue oxygenation like I discussed earlier. The patient's head should be elevated at 30 degrees. Extra care should be taken to make sure that wound dressings, trachea tube tie, and cervical collars do not compress the jugular veins. CSF drainage via a ventricular catheter is a safe and generally reliable method of returning ICP value to normal if it exceeds more than 22 mm mercury. IV administration of hypertonic saline or mannitol is an effective method to reduce intracranial pressure by creating a temporary osmotic gradient towards the intravascular space. Mannitol has its side effects, such as acute renal failure, pulmonary edema, rebound of existing cerebral edema by accumulation in brain tissue due to damaged blood-brain barrier following trauma, and hypotension due to its diuretic action. Therefore, hypertonic saline may be preferable depending on local hospital guidelines. Watching sodium level is important to control intracranial pressure. Please completely avoid hyponatremia whatsoever, and we should aim the serum sodium level around 145 mmol per liter. In patients with traumatic brain injury, hyponatremia could be due to treatment with mannitol infusion or due to central or neurogenic diabetes insipidus. We should consider treating cranial diabetes insipidus cautiously with desmopressin infusion if hyponatremia and polyuria are getting worse, leading to systemic hypotension. High doses of barbiturates, such as phenobarbital and thiopental, reduce cerebral metabolism as well as intracranial pressure. However, due to notorious side effects such as hypotension, hypothermia, immunosuppression, and risk of infection, they are only indicated as a last resort together with decompressive craniectomy. Secondary decompressive craniectomy is usually done to control refractory intracranial hypertension. It is an effective procedure to give the swollen brain more space, but it is indicated only when medical therapies fail to control ICP, or the risk of associated complications is extremely high. According to recent studies, decompressive craniectomy may show survivor benefit, and it may also risk survivors having severe cognitive and physical disabilities. Mild to moderate therapeutic hypothermia was thought to alleviate intracranial hypertension by reducing cerebral metabolism and blood volume. Nevertheless, recent trials suggest that therapeutic hypothermia has no effect or could be even harmful due to risk of coagulopathy and bleeding. Therefore, it is not popular anymore in management of traumatic brain injury. Intracranial infections such as meningitis, brain abscess, and subdural empyema are complications of penetrating injuries caused by stabbing, shooting, or by a blast, allowing entry of bacteria through depressed skull fractures or basal skull fractures. Prevention of intracranial infections can be done by early recognition of risk and mechanism of injury, followed by adequate surgical debridement of the wound, repair of the dura mater and skull, and the sensible use of antibiotics. Most of the intracranial infections in traumatic brain injury are avoidable, and septicemia resulting from that is very rare. The treatment of established intracranial infections include the drainage of pus and the prolonged use of antibiotics as guided by pus, blood, CSF culture, and sensitivities together with clinical response. Seizures are common after traumatic brain injury, especially after presenting with focal neurological signs, after operative evacuation of hematoma, penetrating injury, or intracranial sepsis. A seizure in a comatose patient is a life-threatening emergency because it can enormously increase the cerebral metabolic demand for oxygen and also raise intracranial pressure and subsequently decrease cerebral perfusion pressure. Late seizures, which appear after 7 days from the injury, imply a permanent risk of epilepsy, and long-term prophylaxis with anti-epileptics should be considered. Hence, our aim is to prevent seizure activities. Levetiracetam, phenytoin, and carbamazepine are shown to be helpful, yet the choice of agents could be varied depending on local hospital guidelines. Some drugs commonly used on the ICU should be avoided or used with caution. It is useful to review current medications with intensive care pharmacists and to consider discontinuing them if suspected to be responsible for seizures. Patients with traumatic brain injury may require the management of other extracranial injuries. For example, they may need surgical stabilization of spinal cord lesions, abdominal surgery for hemoperitoneal and visceral injuries, orthopedic procedures for pelvic and long bone fractures. Lastly, I would like to discuss late complications of traumatic brain injury briefly. Post-traumatic hydrocephalus could occur in approximately 2/3 of all patients suffering from severe brain injury following meningitis or procedures like primary and secondary cranial decompression due to impaired CSF absorption. Ventriculoperitoneal or ventriculoatrial CSF shunt will be required as the treatment. Sunken skin flap syndrome can be seen in patients several weeks to months after large decompressive craniectomies. They can present with fluctuating headaches, neurological deteriorations with focal signs, impaired consciousness, epileptic seizures, and neuroendocrine abnormalities. These patients are also at risk of paradoxical herniation when they undergo diagnostic lumbar puncture or therapeutic lumbar CSF drainage. Cranioplasty may be helpful to avoid secondary neurological deterioration. Moreover, it will benefit patients from cosmetic point of view as well. 5 to 15% of patients with traumatic brain injury could be complicated by post-traumatic meningitis. Risk factors include open and contaminated wounds, CSF leaks through basal skull fractures, and ventricular catheters for ICP measurement. We need to follow local protocols to consider antibiotic prophylaxis in such patients. Post-traumatic meningitis is an emergency, and high-dose empirical antibiotics need to be started straight away as soon as CSF samples have been sent for gram stain and culture, since the mortality of untreated bacterial meningitis is high. Intervention of risk factors is also crucial. For instance, persistent post-traumatic CSF leakage should be treated surgically, and infective ventricular drains should be removed and replaced. Carotid cavernous fistula can result from injuries to the internal carotid artery, and it is more common in blunt trauma than in open injuries, and associated with a basal skull fracture. It can lead to ipsilateral visual loss, subarachnoid and intraparenchymal hemorrhage, and cerebral ischemia due to shunting of blood from the major artery territories. Transcranial Doppler and cerebral angiography are useful investigations. The main treatment is to close the leaking fistula by endovascular or open procedure. According to data from large studies by developed nations, 1/3 of patients with severe head injuries die, 1/3 recover, which mainly occurs within first 6 months, and 1/3 of the patients remain disabled. This is the end of the traumatic brain injury series. The key take-home message in management of patients with severe brain injury is to prevent and mitigate the risks and complications of secondary brain injury, and to maintain the cerebral perfusion pressure by controlling the factors such as mean arterial pressure, intracranial pressure, PaCO2, blood glucose, and sodium. I hope this series is useful for you. If it is, please share with your friends and colleagues. I'll see you in the next video. Take care.